Welcome everyone to our Thursday afternoon webinar. My name is Lourdes. I am a patient advocate with the Cholangiocarcinoma Foundation. I'm going to wait a few minutes as everyone logs on, gets connected to sound. I want to just share that in next week we have a patient support group. And if anyone is interested in attending that, please register for it. Today, I have the pleasure of introducing Caitlin Musto. She is a member of the Cholangiocarcinoma Foundation Nursing Advisory Board. She is a physician assistant at Mayo Clinic in Jacksonville, Florida, who specializes in the management of primary hepatic malignancies. Welcome, Caitlin.
Thank you, Lourdes. I'm happy to be here. So hello, everyone. Today, we'll be talking about management strategies for patients with cholangiocarcinoma and biliary issues. These are the learning objectives for the webinar today. Hopefully, by the end, you'll be able to summarize the diagnosis of cholangiocarcinoma, identify the signs and symptoms of biliary obstruction and acute cholangitis, outline different types of stents and drains to treat biliary obstruction, and understand how to care for your biliary stents and drains. So let's start back at just reviewing an overview of what is the biliary system, how does it work, and how does it all fit together. So a bile duct is a tiny canal that connects your liver, your gallbladder, and your intestine. And together they form your biliary system. Your biliary system begins in your liver in the upper right quadrant of your abdomen. There's tiny branching ducts inside your liver that collect bile. These are called the intrahepatic bile ducts. These form larger branches called the right and left hepatic ducts. You can see them in red here in the picture. From there, these two branches join outside of your liver to that area that is green called the common hepatic duct. This is connected to the gallbladder and the cystic duct. And your common hepatic duct forms the common bile duct, where about half of the bile flows from your liver directly into the gallbladder. The other half goes into the main trunk of your biliary tree. So bilirubin is a yellow-colored byproduct of hemoglobin, and this comes from the breakdown of red blood cells. The liver uses bilirubin to make bile, which is stored in the gallbladder. And what this does is bile contains acids that aid in digestion of fats and proteins. These acids can be damaging to other organs that aren't designed to carry them, so that is why it's so important that this system functions well. So cholangiocarcinoma, as you may know, is a primary hepatic neoplasm resulting from malignant transformation of cholangiocytes, which are the epithelial cells lining the biliary tree or your bile ducts. It's the second most common primary hepatic neoplasm, and overall incidence is increasing. About 90% of these are classified as adenocarcinomas, and patient survival is highly dependent on the location and extent of disease when it's diagnosed. These are some of the different locations of cholangiocarcinoma. Letter A shows an intrahepatic lesion, so this is inside the liver, arising from the bile ducts. B shows a perihilar cholangiocarcinoma. This is a lesion that happens right at the bifurcation of the right and left bile ducts. And then C is a distal cholangiocarcinoma or extrahepatic, which occurs in that main duct outside of the liver. These are different types of biliary compression or obstruction. You can have intraluminal or extraluminal compression or obstruction blocking the bile flow. So in the top pictures, you can see in picture A, there's a discrete mass blocking the bile duct. In pictures B1 and B2, these are more of a stricture type appearance where there's still inflammation and scarring there that blocks the bile flow. The bottom pictures show extraluminal compression, which is a tumor compressing from the outside of the bile duct, causing extrinsic compression. So why does this matter? So what happens when the bile accumulates, this can lead to jaundice, and it blocks the flow of the bile out of the liver, and all of those bile acids and things build up. This can cause cholestasis, which is slow flow through the liver, and this can ultimately lead to bacterial growth or proliferation. This can cause biliary dilation because the bile's obstructed and not able to be excreted the way that we would hope. And if the pressure is not relieved, this can eventually result in liver dysfunction. Again, normal substances that are excreted by the liver backflow into systemic circulation, and this can cause infection and other issues. So what are the signs of biliary obstruction? Jaundice, which is the accumulation of bilirubin in the blood. Again, this is a yellow tinged byproduct, so this can cause yellowing of the eyes and skin. About 90% of times patient presents with biliary symptoms. It can be painless jaundice, so it's just this yellowing that patients notice. You may see clay-colored stools. That's because the bile is obstructed, so it's not making it into the stool to give it that brown color. Patients may have dark urine, fatigue, itching or pruritus. They may have loss of appetite or weight loss, can also have right upper quadrant pain, fever, or chills. So acute cholangitis is a medical emergency. These are the 5 signs of acute cholangitis in the picture here. And as you can tell, they're similar to those of biliary obstruction. The difference here is patients are infected. You can get fever or chills, and typically patients will be admitted for management with antibiotics, IV fluids. There may be a GI consult or an IR consult for consideration of an ERCP or a PTC tube. We'll talk more about those as we go along. And antibiotics may be required as well. So a little bit more about how we diagnose cholangiocarcinoma. Usually, diagnosis occurs when we get liver chemistries or tumor markers. IgG subclasses is another term that you may hear. This is another type of inflammation that can cause something that looks like a biliary stricture but isn't actually a malignancy. Imaging, usually ultrasound is the initial imaging, and it'll show biliary dilation. But MRI and MRCP is really the gold standard for examining the bile ducts to determine the extent of cholangiocarcinoma. At this point, I just want to say, when patients are being considered for a cholangiocarcinoma diagnosis, it is important that your healthcare team is thinking about potential referral to a transplant center for evaluation of deceased donor transplant or potentially even a living donor transplant. So endoscopy is another mainstay of diagnosing cholangiocarcinoma. EUS is used. This is an endoscopic ultrasound to confirm lymph node involvement or to sample regional lymph nodes to rule out metastasis. ERCP, which you may be more familiar with, can be both diagnostic and therapeutic. This is often what is used for the placement of biliary stents and drains or to get bile duct brushings, which can result in the cholangiocarcinoma diagnosis. So endoscopic ultrasound, as I said, is more of a diagnostic technique. This is performed by gastroenterologists. They use an endoscope that goes down your throat to insert a catheter, which can be used therapeutically for stent placement, particularly in a patient who's maybe had a surgery, so they have complicated anatomy, or if an ERCP was attempted but unable to be completed for some reason. ERCP is also performed by gastroenterologists. This is another procedure where an endoscope is used. In this case, there's a catheter that injects contrast into the bile ducts, and this can identify the site of obstruction. This can also be used for biopsy, brushings, or stent placement. So when we're talking about diagnosis, the next step is to consider potential treatments. Liver resection is considered the standard of care for all cholangiocarcinoma subtypes, but only about 1/3 of patients are resectable at the time of diagnosis. This can be due to the location and extent of the tumor or potentially another underlying liver issue. Liver transplant can be considered as an alternate treatment option, and there is a protocol with chemo and radiation that go along with this treatment. At this point, liver transplant is only indicated if a cholangiocarcinoma is deemed to be unresectable. However, more recently, liver transplant is being considered at some centers for very early single small tumors of intrahepatic cholangiocarcinoma as well. Just another important thing to note when patients are undergoing the workup for cholangiocarcinoma, to make sure your healthcare team knows not to biopsy the actual mass lesion, as this can be a contraindication to liver transplant. So let's say you get diagnosed with cholangiocarcinoma, you've been on treatment, and you're undergoing a surgery or some other procedures. Some of the post-procedural biliary issues that can happen include a bile leak. When this happens, it's when bile leaks out of the ducts transporting bile to the small bowel. Symptoms are similar to those that patients can experience with biliary obstruction, and sometimes this can take a couple weeks even after surgery to fully present to itself. Oftentimes patients present with right upper quadrant pain or fever. They may have nausea or vomiting. The white blood cell count can potentially be elevated in the labs, and this can result in an inflammatory reaction or an abscess, or biloma is another term that you may hear. And this is a picture here of a endoscope, and you can see this is the main biliary tree, and all of this is bile leaking out into the system. Another potential thing that can happen as a result of procedures or surgery is a biliary stricture. Again, this is similar to the same type of symptoms that you would see with biliary obstruction, just even in the diagnosis of cholangiocarcinoma. There are other reasons you can get this as well. And these pictures are just demonstrating, again, there's the difference between the bile duct thickening or the intraluminal compression versus the tumor on the outside causing compression or the extraluminal compression. So this is a nice picture that's actually available on the Cholangiocarcinoma Foundation website, and it just kind of summarizes a lot of what we've talked about already, that there are different locations where cholangiocarcinoma can be diagnosed: intrahepatic, which is inside the liver, coming from those little bile ducts; the perihilar cholangiocarcinoma, which is at that bifurcation of both the right and left ducts; or the more distal cholangiocarcinoma. Again, the symptoms of biliary obstruction tend to be obstructive jaundice, which is that yellowing of the skin and eyes, dark urine, pale stools, or itching. So interventional radiology, a lot of times when I see patients in clinic and they come to see us, they have never heard of an interventional radiologist. They don't know what an interventional radiologist does. And really what they do is they perform minimally invasive procedures using imaging guidance. And at some point in your journey with cholangiocarcinoma, you're probably going to see one of them. So interventional oncology is a subspecialty of interventional radiology, where there is minimally invasive techniques used to actually enhance cancer care. And they play a key role in multidisciplinary integrated cancer treatment, even supported by the NCCN guidelines. So it's not just the biliary stents and drains that the interventional radiologist may help you with. There's also potentially options to treat cholangiocarcinoma as well. All right, so let's get into the biliary stents and drains. So the first thing to understand when we're talking about biliary stents and drains is the difference between an internal and an external stent. So an internal biliary stent is primarily placed by a GI physician through either that EUS or that ERCP that we talked about a little while back. So this is when they use an endoscope to get into the bile ducts, find the obstruction, and place a stent. As you can see in the image here, there's that area of stricturing, and the stent is placed to maintain open passage for bile. Stents can be plastic, they can be metal. There's ones that are called fully covered versus partially covered or uncovered metal. Really the best initial choice until a treatment plan is finalized is going to be a plastic or self-extending covered metal stent. What can happen sometimes is when a metallic stent is placed too soon in the treatment process, if it hasn't been completely decided if a patient's a surgical candidate, those can be really challenging to remove because they're more permanent. That's what also makes them kind of nice, because they tend to not need exchanges often. But this is where you really need to talk with your healthcare team to make sure everybody has an understanding of what the ultimate treatment plan would be in your case. So a percutaneous transhepatic cholangiography, or PTC. So this is performed by IR, and this is a procedure that can be done to place a biliary drain. And a lot of times you may hear an external drain, a biliary drain, a PTC tube, all those types of terms. And this is where it comes from. So this procedure is performed by interventional radiology. And to do this, a needle is passed percutaneously through the skin into the liver, then into the bile duct. Contrast is injected to try to find the area of obstruction. A thin wire is then passed through the center of the needle into the bile duct, and a drain tube inserted over top of it. One end of the drain remains in the bile duct, and the other will come out through your skin. This is a picture of a biliary bag here, and that's what bile looks like. It's that dark motor oil colored appearance. A question that we often get from patients, they'll call because they're concerned that the bile maybe changed color or something like that. That's normal. This can range from yellow to green to brown. So those are things to expect if you're potentially having a biliary drain in place. This is another picture here of what the actual images look like when a radiologist is doing the procedure. So this is the biliary tree, and you can see that this is the tube being inserted into the bile duct through the liver. Here's the narrowing of the bile duct down here. You can see it goes from big to small. And then this is when the tube is passed through that narrowing into the small intestine. So this is an external biliary drain. Again, these can be called a PTC tube. You may hear it called that rather than an external biliary drain. And these are placed percutaneously into the bile ducts through that procedure I just described. Typically, there's a catheter attached to the drainage bag. And in this case, an external drain is used in the setting of complete biliary obstruction where the blockage cannot be traversed by the drain and the bile is draining outside of the liver into the bag. These typically need to be changed at regular intervals to prevent any occlusion or infection. And this is what the end of that drain tube looks like with these little side holes, and it curls into that pigtail type shape. So this is an internal external biliary drain. Same concept as the other drain we just talked about, but in this case, the radiologist is able to get the tube through the area that's blocked to drain into the small intestine. So this drain allows the bile to flow in two directions. One is out into the external collecting bag out here, outside your skin, and the other is into the small intestine. This is the most common type of drainage catheter. This must also be changed at regular intervals to avoid any occlusion or infection. So this is what some of the setup looks like for these external biliary stents and drains. So this picture here shows that other little picture that I just showed of this is the actual biliary tube here. It goes to a tubing that then goes to the external bag. A lot of times patients will use a safety pin or clip, although I've seen very creative ways that patients do these to make it comfortable for them. Sometimes these tubes can be capped. So if you're able to remove the external drainage bag, you may be able to place a little cap here. That's what this is showing, to allow the bile to drain through the tube into the small intestine and no longer outside the body. These are just some more pictures of what this looks like. This is an actual setup here. So this is the area with the stopcock. This is the drain going to the body. And then this is the external tube here going to the biliary bag. And this is another picture of what it looks like capped. So what should you expect when you come in for these procedures where there's an internal, external, or external biliary tube or PTC tube being placed? It's likely that you'll receive some kind of sedation. Usually what we do here is is called moderate sedation, which is a mix of fentanyl and Versed. It's enough to relax you and keep you comfortable for the procedure, but not so much so that you're out completely like a general anesthesia or something like that. Usually you'll need to arrange for someone to accompany you to and from the appointment and to drive you home if you're getting any kind of sedation. You'll also need to be fasting prior to the procedure. And you'll want to check with your healthcare team for instructions if you're taking blood thinners or require diabetes medications. So after the procedure, it's recommended that you rest, not to drive or do any kind of really strenuous activity. For the day of the procedure, you probably wouldn't want to return to work or school. Again, when you get sedation, you can be a little bit groggy for the rest of the day. And it wouldn't be uncommon for the drainage in the bag to have some blood in it for maybe about 24 hours or so. This is normal, but shouldn't be persistent. Discomfort can occur at the drain site, and this is expected for the first couple of days, but should improve. If it doesn't, that's another time that you may want to reach out to your healthcare team. For about a week after the procedure, it's important not to lift or move anything more than 10 pounds and to really try to avoid strenuous activities while the tube is there. So after the procedure, when you're able to remove the gauze, usually that's about 24 hours or so later, you can shower. You want to allow warm water to run over the tube site and pat it dry. You do not want to submerge these. So no baths, pools, hot tubs, oceans, lakes, none of that while these tubes are in place. Typically, it is recommended that these tubes be flushed. The amount and timing will vary a little bit depending on your provider and where you're being seen. Oftentimes here, we recommend about 5 to 10 cc's twice a day. If a tube is prone to clogging, it may need more frequent flushing or exchanges. And this again is a picture here of the drainage catheter with the stopcock. You'll move this to away from where you want the flush to go so that it goes to the right spot. And really you want to change the dressing often enough to keep it clean. We talked a little bit about the capping trial. So that's where you have the internal, external biliary drain, and you can potentially remove that drainage bag to try to allow the bile to drain fully through the intestine. That usually can happen about 24 to 48 hours after the biliary system is initially decompressed. So some of the things that you want to look for when you have a drain is, again, any of those signs of biliary obstruction. It's not uncommon for the amount of bile to fluctuate, but it shouldn't stop completely. That's usually a reason to call your healthcare team if that happens all of a sudden, especially if you develop any of these symptoms. This is just another picture here. This is what the tube looks like coming out of the skin, and there's a suture that you can see there that's attached. You'll want to discuss the frequency of exchanges with your healthcare team, your GI team, or your IR team. Usually about 8 to 12 weeks for the internal stents to be exchanged, and typically about the same for the external or the biliary drains to be exchanged as well. So the removal of these, this is the side of a drain after it's been removed. You can see there's a little hole there. That's normal. It'll usually close in a couple of days. There may be just a little bit of drainage that you'll see on a gauze that you put over that just for a few days after. Typically, if it's more than just a little bit or there's a lot of drainage coming out of that hole there, you would want to contact your healthcare team for more instructions. Usually this can be performed without any sedation. Sometimes there could be a little bit of moderate. Another study is performed to look at the biliary system and see what things look like. And if it looks okay, these can be removed. And one thing that's important to know is when these are removed, anytime that you're doing any manipulation to these types of tubes, it's possible to develop a transient episode of cholangitis where you may spike a low-grade temperature or have a little bit of pain. So you need to monitor for those symptoms and contact your team if that occurs. Sometimes you'll even maybe be prescribed a preemptive dose of antibiotics just in case this were to happen. So these are just some things to consider when you have an external biliary drain. Usually travel on an airplane is okay. There may be some documentation that's recommended, but typically this is not something that TSA would require. It's okay to shower, but you don't want to submerge in a bath or a pool. There are some techniques that you can use to cover the area too, like the AquaGuard or the Saran wrap. It's okay to work and exercise after about 24 hours, as long as it's not super strenuous and you're being cautious. I have the picture of the doorknob there because I cannot tell you the number of times I've had patients call because they get their drain caught on something, it moves. So you really want to try to be conscious of the fact that you have something sticking out there. Also, do not cut or trim the tube under any circumstances without talking to your healthcare team and being with them. Again, I've had this happen with some patients where for whatever reason, they've cut the tube and it actually gets retracted inside the body and they've needed a surgery to go find it. So when do you call your healthcare provider? Anytime that you're worried about signs or symptoms of infection, if there's blood in the drainage bag after that first 24-hour period, if you have worsening pain, if there's odor or pus or leaking at the insertion site, a little bit of this is okay, but anything that seems more concerning is persistent, where you're worried about infection, those kinds of things, you really should be calling your team. If there's, again, an acute onset of no drainage and your tube is connected to a bag, we worry then that it's potentially clogged and you could end up developing cholangitis if you have any difficulty flushing the tube. High output drainage into the bag over a long period of time. So for a while, sometimes this will happen and your healthcare team can advise you on what they're expecting. But if there's a high output daily, this can cause electrolyte imbalances. So your team really needs to know. Another reason would be if the stitches become dislodged because we don't want that tube to fall out of the track, or if the tube moves or falls out. So I just wanted to show a picture here. This is the nursing advisory board for the Cholangiocarcinoma Foundation, which I've been lucky enough to be a part of for some time. Paige Griffith is our chair, and I think there's actually a few of us that'll be doing these webinars over the coming months. And I wanted to also bring attention to the Cholangiocarcinoma Foundation website. Given that you're all on here, I would suspect that you're familiar with all of this, but it's really a fantastic resource for patients. When you're newly diagnosed, this orange button hits you right when you get to the page, and these are all of the things the patients can have access to get in touch with each other and find some healthcare providers. One of the things I wanted to bring attention to specifically was the Cholangio Connect, where you can become a mentor or request a mentor. If you need support or you want to give support, this is a really great resource for you guys. Another is the patient and caregiver support group, which I know Lord's talked about earlier when we signed on. And this is just an example of all the resources that the Cholangiocarcinoma Foundation offers for you guys. This is the biliary emergency card. So really specifically related to the stents and drains, this is great. If patients come in with this, we know exactly who their care team is, when their tube was placed, what type of tube it is. So if you haven't done this and you have a biliary stent or a biliary drain, I recommend you look this up on the webpage and fill one of these out. The conference, the annual conference, is in Salt Lake City in April. And it's really a great time for patients and healthcare providers to come together and collaborate. So some key takeaways for today. Acute cholangitis is a medical emergency. Patients really need to be aware that if you have a biliary tube in place or a stent and you develop any of these symptoms, that can be a life-threatening issue. If you get infected, you need to go to the hospital, you need to call your healthcare team, and you have to get started on antibiotics, and that obstruction needs to be relieved. Interventional radiologists play a key role in the care for patients with cholangiocarcinoma. Obviously, there's multiple different types of stents and drains, and these can be confusing. So really try to lean on your healthcare team to make sure you're understanding what type you have, what the instructions are for it, and how to take care of them. And again, the Cholangiocarcinoma Foundation is an excellent resource for cholangiocarcinoma patients. And finally, really in caring for patients with cholangiocarcinoma, it's a multidisciplinary approach. You need to engage all of these people on your team. We're all here to help you, as well as your family and caregivers. So thank you for the opportunity to talk and present to you today, and I'm looking forward to your questions.
Thank you so much. If you have any questions, please put them into the Q&A or the chat, and remember to make your questions general in nature. I know we had one come in. Is a biliary stricture a common malignancy when spread from gastric cancer as a primary?
So I'm not quite sure how to answer that one. So, I mean, a biliary stricture, there's many reasons that you can develop a biliary stricture. If you had a gastric primary cancer, it could be possible that you had metastases where they're then creating compression on the biliary system in the liver. I can see how that would happen. If there's a biliary stricture, again, it's important to monitor for signs of biliary obstruction. And that's one of the common presenting ways people are diagnosed with cholangiocarcinoma. I hope that answers your question.
I'm sure she can let us know. Someone is saying thank you for your presentation. If you can describe creative ways to manage attaching the bag, how strenuous activity can be, how to cover the drain insertion site after a shower. It sounded like it could be uncovered during the presentation.
So usually what you want to do is, and again, I think that some of these things are very nuanced. So I would really recommend you reach out to your team. I think different providers and different practices are going to have different recommendations that they give for some of these things. So I would definitely not want to give you any conflicting information about any of that. But some of the creative ways that I've seen patients with their biliary stents and drains, I mean, if they're capped, you're able to kind of wrap them and cover them with a dry gauze. I've seen patients create little pouches or purses that they can have the bag in and kind of put it on their shoulder. So it's taking some of the pressure off of their shirt rather than just using like a safety pin or something like that. As far as covering the tube for the shower, there's that AquaGuard or those other seals that you can do. Although a lot of times, depending on the circumstance, again, you don't want to submerge it, but soap and water over it, pat it dry. But again, I would recommend reaching out to your team for specific instructions.
Do you have any suggestions on how caregivers can assist? For example, how would they identify the cholangitis symptoms and how fast to get treatment?
So caregivers are essential for some of this. A lot of time caregivers are the ones that notice first, actually, when patients have that little bit of yellowing in their eyes or their loved one just feels fatigued or isn't quite right. It seems like a lot of times we're getting the calls from the caregivers where they're saying like, yeah, I mean, there's this low grade fever, there's this big pain, they're just not themselves today. And sometimes it can be fairly subtle until it's not. And I think that's where the caregivers just being involved in the patient care and really knowing when to reach out to the team and not being afraid that you're bothering the healthcare team by calling them with some of these questions to get these answers, because it can be an emergency. Again, anytime a patient has fever, chills, jaundice, pale stool, dark urine, those are the things you're looking for, particularly if there's a stent or drain in place that should be mitigating that from happening.
How long do metal stents typically last?
So metal stents, depending on the type, can stay in for a long time. Usually they're put in as more of a palliative measure, so they're not ones that are getting exchanged. So that's why it's important when one of those is placed to have an understanding of what the ultimate treatment plan will be. Now that's for the uncovered stents. For the partially covered stents, those ones can be removed, but tend to last a little bit longer than maybe the plastic stents because they don't tend to get clogged as quickly. But usually, again, I would reach out to the GI folks who are placing them, because this will vary too. Everybody has, you know, their typical treatment algorithm for these things, but a lot of times the stent exchanges happen somewhere in the area of about 8 to 12 weeks, but it can be different depending on the type of stent you have.
And then are the metal stents those that are considered permanent stents?
So again, not all of them. It would depend on which type is placed. The uncovered are more of the permanent ones.
Is there any type of barrier one can use to allow for swimming with an internal external drain capped?
That is a good question. I have actually not been asked that question. I will have to look into that and get back to you.
And we could, yeah,
Typically,
we'll get you the answer.
yeah, I'm not sure. I'm sorry. I mean, typically we advise people not to swim. I'm not aware of one, but I would be interested to find out for you.
How long and how well do internal stents work, and how often can they be changed?
So same thing. I think it really depends on the type of stent. It depends on where the obstruction is. So that 8 to 12 weeks is a general time frame that we usually look at these things. Some patients need to come in more commonly because they're getting obstructed or clogged. So there's not really a one size fits all answer for that, but when they work, they tend to work well.
Okay. How can we proactively prevent cholangiocarcinoma patients from becoming septic, other than looking out for symptoms like fever, chills, etc.?
There's not really a great way to do that. I mean, definitely if you have a drain in place, you want to make sure that you're taking care of it, you're flushing it. That's a big thing. If you're advised to flush your drain, make sure you're doing that. And if for whatever reason you're having difficulty with that, reach out to your team, because when those things become clogged, that's when the bile isn't able to appropriately drain, and that's when cholangitis can happen.
Okay. If a stent was attempted but aborted due to location of a mass, is there more than one style of stent? And can other stent styles, size, or length be attempted?
So it's not necessarily the stent, I wouldn't think, as much as the approach. So if endoscopically, for whatever reason, they weren't able to place the stent, that's where potentially maybe a more percutaneous approach with interventional radiology might work. If it's one of the situations where it's an interventional radiology approach, there are sometimes, if it's really challenging, where actually GI and interventional radiology can team up and try to come at it from both the endoscopic approach as well as a percutaneous approach. So the answer is yes, there probably are other attempts or approaches that can be made, but again, it would depend on the specifics of the case.
Okay. Can you talk more regarding the stent type? Which condition needs a metal stent versus a full covered stent, or a partially covered stent, or plastic stent?
So I think that's really a conversation when you're meeting with your GI physician, given where you're at in your treatment, what the ultimate treatment plan may be. That's where those decisions are really going to be made. The plastic stents, again, are more temporary. So they're sometimes ones that'll be put in maybe more initially when we're still figuring out where, what exactly things look like, what the plan may be. Whereas again, the metal stents tend to be more palliative. So in somebody that maybe you've exhausted a lot of the treatment options, that may be a time to consider a metal stent. But these are just examples. There's other instances where either of these types of things can be considered. And that's where I would recommend really having a detailed discussion with the GI provider doing your ERCP to place these stents, so that you understand what they're placing, why they're placing it, and the thought process that went into choosing one over another.
Okay. Do you often see gastric cancer with Mets to the biliary duct gallbladder? Are symptoms of Mets to the gallbladder bile duct same as CCA?
So I don't personally see a lot of patients with gastric cancer. I'm sure that it can metastasize to the liver, but it's not one that I see frequently in my practice. Cholangiocarcinoma and gallbladder cancer are closely related, and sometimes there can be difficulty in determining, at least initially, where the cancer is coming from, whether it's the gallbladder or the bile ducts. So that can sometimes take a little bit of time to figure out. But any of these things have the ability to metastasize to different areas.
Do patients who have had Whipple surgery need stents?
Sometimes they can. And that's one of the situations too, when the anatomy has been changed, that an ERCP may not always be as successful. So that may be where they consider an EUS or a percutaneous approach. But yes, that does sometimes happen where a patient after Whipple would need a stent.
Can you get an MRI if you have metal stents?
That's a good question. Yes. Usually they are MRI safe, but good to let people know that you have one just to be sure.
Yeah. If someone's had biliary internal stents placed, but they recently had to do an external drain due to a surgical wound, and the bile continues to leak out into the drain and drain bag, is there anything that you, or your opinion on this potential situation? Like, what would you recommend?
So there's internal stents and an external drain. Is that the question?
Yes, and yes, internal stents and an external drain.
So it would depend a little bit on where the external drain is going. So this is a circumstance where if you had the percutaneous biliary drain that's able to be more of an internal external drain and it can drain into the small bowel, sometimes that can be capped to give it a try so that you're not draining the bile outside. And I guess that would depend too on where the internal stents are placed. But so it's hard without all the specifics to answer for sure, but it sounds like maybe a situation where a capping trial could potentially be considered. I'm not quite sure 100%.
Thank you. When there is a leakage at the external drain site plus bile going into the bag, what does that indicate is going on?
I mean, sometimes those little side holes that are on the biliary drain can get clogged. It may not be in a complete occlusion where there's still an ability for some of the bile to go the way that it's supposed to. But anytime there's bile coming out from around the tube site, that's a reason to call your team to make sure that you can get the tube checked and make sure everything's functioning appropriately.
How do doctors decide when it's time to remove the drain?
So that's where we would usually get, so it depends a little bit. So if you're able to have the tube capped, and the drain is going into the bowel and the bowel is draining appropriately that way, usually about the 8 to 12 week time frame is what we say for exchanges, or sometimes to recheck to see if it looks like the stricture or obstruction or whatever may be there has resolved. It may take longer, but that's where we do that cholangiogram to get a picture of what the bile ducts look like and try to get a sense of whether or not we still think there's a stricture or obstruction there. Anytime the biliary drains are removed, there's always a risk that you may end up with symptoms afterwards of obstruction and potentially need it replaced. But those are usually you'd have a cholangiogram prior to the tube removal to take a look at things.
If someone has ascites, would a drain be needed as part of treatment, or is there any particular treatment that's recommended for ascites?
So ascites is a little bit different. So for these drains, we're talking about draining the bile ducts, whereas ascites can happen sometimes in patients that have underlying liver dysfunction where fluid is building up into the abdomen. So for that, it's usually more of a paracentesis that's recommended. And that can be done by radiology as well. But in that case, you're inserting a needle into the skin and draining the fluid that way. That's a procedure that patients can need. It can be fairly infrequently depending on the circumstances, or we actually see some people multiple times a week for that. But they're two separate processes there.
Perfect, thank you. I think I got all of the questions. If anyone else has any question, please put it into the Q&A or the chat. This individual uses Tegaderm to cover the dressing and secure the tube, but sometimes it's not strong enough. Do you have any recommendations or on a device to help secure the tube?
So there's lots of different things out there. I mean, I think Tegaderm definitely works. I think when the tube is capped, you can try doing more of a gauze with tape around the gauze to coil the drain under the gauze and make kind of like a little pocket there sometimes, because that tape could potentially stick a little bit better. So unfortunately, these are just some things that, like I said, patients get creative with. And, you know, I've seen all different ways that people do it. So I would reach out. That's probably another great place where, if you're on the cholangiocarcinoma website, to try to get some different ideas from other patients in the group as well.
Perfect. I think those are all the questions. Thank you so much, Caitlin. This was great.
Yeah, thank you for having me. I really
It's been really
appreciate the
helpful.
opportunity to be here.
Yeah, and then if anyone has any other questions, please feel free to let us know. We can always try to help answer those for you. Thank you, everyone.